Last but not the least case, I would call Dr. Jalal Khan from PIC Hospital to present his case. Title is Zero Contrast Decay Nano Crush Stenting in Renal Impairment. Dr. Jalal.
Bismillahirrahmanirrahim. Over here, I am actually presenting a case which we normally don't face, but we do face it rarely. A 46-year-old hypertensive smoker male presented with history of chest pain and was diagnosed as case of non-ST elevated MI. His echo showed left ventricular hypertrophy with fair systolic function of round about 55% ejection fraction. His Gray score was 115, hemodynamically stable, but the one thing which came as obstacle or bar, that was actually has creatinine derangement. With 2 occasions, his creatinine was 4.3 milligram per deciliter, and its second occasion it was 4.2 milligram per deciliter. He was admitted in the hospital and treated, but the angio was done of the patient in the hospital. Angiography was done in hospital, and we can see there are 2 lesions, severe mid LAD and proximal diagonal 1 of good diameter, which shows stenosis, severe stenosis in these lesions. Its angiography was actually done at a low non-ionic contrast of amount of around about 12 ml. After discussing it with her team, it was being decided how to approach this patient, and we also involved in hospital nephrologist, and he as well gave his opinion regarding this patient and decided that we should proceed with PCA of the culprit lesion. So after her discussion, her team discussion, we came to this point that we have to proceed with IVS guidance. That was the strategy which was actually opted by this patient. Without any contrast, with fluoro-guided, BM was being placed distally in LAD, and over here the second BM wire was placed in diagonal 1. Diagonal 1 was pre-dilated with 2.75 balloon at 12 ATM. At the same, after pre-dilatation, IVS was done of the diagonal 1. Here we can see the IVS point over here for the proximal and distal. IVS was as well done in order to know the landing zone, the diameter, and as well as the length of the lesion, and the stent estimation, which came round about that diameter is 3.26, length 21 millimeter, and followed by IVS of the LAD over here, which showed diameter of round about 3.4 millimeter, and the lesion length was estimated 35, and we took a stent of round about 38 millimeter. So this area over here shows the ostium of diagonal 1. Based on the IVS measurements, a 3x15 NC balloon was placed in LAD, and 3x24 drug-eluting stent was advanced into diagonal 1. But the most important question over here was that how would we actually optimize the stent of diagonal 1 at the ostium without giving any contrast, as because this is the only way where most of the views are taken in order to know the positioning of the ostium of diagonal in the LAD. But we took a decision, we actually opted a DK nano crash technique, which allows us to inflate the NC balloon in LAD. We inflated the balloon at around about 6 ATM, and we pulled and kept the stent of in the LAD taut. It actually came into like one strut into the LAD in LAD, where the semi inflated balloon was there without giving any contrast over here. So it was actually inflated over there, and the first case was done. Both balloons were actually proximally withdrawn a little bit, and the balloon in the diagonal was inflated again, and the first case was performed simultaneously successfully. So here we again did the IVS of the diagonal in order to know about if there is any under expansion or there is a dissection, but there was actually under expanded stent, for which we used a 3.25 15 NC balloon and pre-dilated, post-dilated the stent over here again. And this final IVS of the diagonal was done, which showed a mean luminal area of 8.2 millimeters square, and it was successfully done. And the second view, we actually took on a stent of LED and 3 into 38 deployed in the LED. Port was done using 3.5 in 16 ATM, and a second case was done with NC balloons, and then the last port was done with the 3.75 NC balloon over here. After doing it, we did the IVS of the LED in order to know if there is any under position, and the IVS was done successfully over here as well, which showed a minimal luminal area of around about 11.1 millimeters square here. Without any giving contrast and with the help of IVS, we came and achieved that there was actually good stent apposition with adequate expansion and no edge dissection. So this was actually a case where we needed to do or use less amount of contrast or either zero contrast. So basically based on his renal impairment, we actually didn't use contrast except his angiographic view. But this was actually the last view that we did in order to save for our record the final view where we can see the lesions properly treated. So this was the final view, and the patient after the next day, following next day at discharge, he was his creatinine was done, which was around about 4 milligram per deciliter, and the patient was advised for follow-up, as well as the patient was advised to follow for regular nephrologist checkup. So that was the final thing. Thank you so much.
कंट्रास्ट तो इस्तेमाल हुआ ना इसमें, जीरो कंट्रास्ट तो नहीं हुआ.
फाइनल रिजल्ट का दिन दिखा रहे हैं.
I mean, with IVS, you would have even avoided the last view, but a very excellent case.
Any comments from chairpersons?
माइक दे दें.
That's really awesome case done, and with a zero contrast, and that's really very great there. Honestly speaking, I'm really impressed by mechanisms and by the methods you were and the tools as well, which you are using for the zero contrast and especially making the patient's kidney safe and as well as patient's heart safe. Great case.
Can we have the first diagnostic image? Can you please display the first diagnostic image? Because this was a case of non-ST elevation MI. So apparently the lesion was quite far from the ostium of the diagonal and looking like a culprit lesion in the diagonal. And LAD, which was a mid LAD, apparently to me it's looking like moderate to severe, not that much severe. So did you thought of doing FFR? This portion is all looking like a stable IHD, isn't it? And the culprit lesion is there in the diagonal, which is quite away from the carina. So was there any suggestion of doing FFR for this LED lesion?
Okay, so that's no doubt there is room for discussion on that point. You know, many a times we come across diagonal branches which show tight stenosis near to a point of bifurcation, and the LED proximal or distal to that region of the diagonal is involved with 60% or 50% plaque many a times. So there are a couple of ways to address this, and I totally agree. One way is to putting a IFR or FFR wire in there, and especially with the advancement of the technology, with if MUFR is there, that's an excellent technology, I think, and it's going to be installed in most of the cath labs of the Pakistan in very near future, because it does not add any cost. Okay, in this case, I think the presenter had not shown the view of the IVUS plaque burden at the point of this bifurcation. So there was a significant plaque of 67% or around something, as far as I remember, it was above 65%. So there was huge plaque burden. You can see one clue to if the IVUS is not added, but one clue is when there is a origin of the septal 1 at this area, the diameter of LED is huge. It's 3.5 or something, and the proximal is huge. So the actual LED is large vessel, and there was a huge plaque burden at that place. So that's why the other plan, if you, by your comment, if I agree, if we only put a stent from the ostium diagonal to the mid diagonal or proximal diagonal, so due to the presence of this plaque at the LED at the point of bifurcation, so there was a chance ending up in dissection or something, especially if we are going with a zero contrast and you are not giving a lot of, the patient's creatinine is not giving a lot of liberty to give, to do a lot of views. So, and that was one of the reasons that the stent sizes, the length especially, you see they were selected, they were a little bit longer than needed. So a bit more metal, I think, but that comment is totally agreed. If you put another, yeah.
One more comment I would like to add on. We can make it this case as simple as possible, as this patient was having a kidney damage as well, and we have taken this patient for a zero contrast. So case is done nicely, but my point is that we can do ballooning to the diagonal, and as well as we can put a small stent in a LED. So we can make it simple as possible. This is one of the point from my side.
My suggestion is also that we can balloon 1:1 to the diagonal, and we can put a small stent in the LED.
So again, can you show the second last or last view, please? The last view. So you see after in the last view, the diagonal is a huge vessel. So the diameter is huge, the length is huge, the IVUS shows a diameter of 3.2. So usually, even when we are proceeding normally in most of our patients, if a vessel is like 3 point something in diameter, doing only a POBA to that, that is usually less of a practice. Okay, I agree. Someone can do that in a primary PCI setting when the anatomy is not suitable and you are later planning for a cabbage or something, or if there is a distal vessel or something. But you see it's a diagonal, that's the only diagonal. And the diagonal has 1, 2, 3, at least 3 branches. So leaving it only to a POBA can be an option, but most of the times, again, you end up putting in a stent.
By looking at the whole scenario, restenosis rate, CKD, young age, that's why I'm saying.
So next slide, please. Next slide. So that was the thing. That was all the time in the mind. So I agree. Various options can be taken. So this was one of the options which operator selected, and he was successfully able to do it with zero contrast. And there are a lot of case reports currently doing nano crush for a zero contrast. So they are getting popular and using IVUS for optimization and taking a final single shot. So there is ultra low contrast and zero contrast. So these two terms and these two categories are now a little bit different from that. In ultra low contrast, you use maneuvers to minimize the contrast to less than 10 ml. And in zero contrast, you perform and complete your procedure with zero contrast. Like in this case, it was completed without contrast. The last injection was only done for documentation. That's mandatory.
Agreed with you, sir. Agreed with the scenario as you have mentioned. It's actually sizable vessel, and we can save the diagonal with the time. But my suggestion is that as soon as we can save the patients with a minimal manipulation and a minimal stent, that will be much more better. The provenance study is always better as compared to two-stent strategy, whatever the data is being suggested.
But I think diagonal is a very important vessel here. If you look at if you can go back, this diagonal is the only diagonal vessel arriving from LED. The whole mid to distal LED is not giving off any other diagonal. So it's a major diagonal. So I think it's a large vessel. It needed to be stented, but opinions can vary.
I have two questions. Excuse me. What was the size of the guide catheter? Which French you used, and what was the frame rate during the PCI procedure?
Sorry. It was a 7 French, it was a routine frame rate. The fluoro is 10 and the cine is also at 10. We have got, a stent boost in only 1 hour of cath labs out of the 5 main cath labs. There are 2 primary, total we have 7, but we have got stent boost in only 1 of them. And this patient was proceeded in the cath lab, which did not have the stent boost at that time, unluckily. So by your comment,
just last
so that's an
comment would be
excellent thought that you have to use. Well, but the quality of fluoro, even on this screen you can see, and the cine which have been saved, I think that was reasonable. While one of the image I remember where the Dr. Jalal has put on the screen is while crossing into the side struts from the middle, crossing with the BM from the middle struts, most of the struts they were visible, so it was reasonable. Personally, it's where some of the operators I see, they use a lot of 30 frames or stent boost. We have it in the machine. Even if I have, I usually do not use it. So
one teaching is that once you are talking about a zero contrast procedure or low volume procedure, you should make the procedure, the teaching is that make the procedure simple one and plan it properly so that you can avoid a 2-stent strategy and avoid a larger guide catheter to be used. Because the last picture, the higher French you used, the more contrast you will inject to delineate the coronary arteries.
So we did not attach the contrast range in this patient to the manifold at all till the last view, and so that was the way we did not give any contrast. Whether the guide is 6 or 7, we did not have the contrast we did not have the ammunition to fire.
I think it was
a nice case, of course, excellent case.
No doubt about it.
Yes.
The only thing is, could you have used IVUS to place the diagonal stent at the ostium? Just at the ostium?
Yeah. Yesterday one case was shown of osteal PCI. So I would admit that this idea did not cross my mind at that time.
Yeah.
So I saw one case in the hall, in the same hall B, in which the osteal circumflex stenting was done. It was an osteal isolated circ lesion, and they kept one wire and IVUS near the distal left main, and they visualized by the IVUS the ostium of that circ, and they placed it, and it was excellent.
Yeah.
So totally excellent idea. I did not.
But your case was.
This was not in my mind when we did that case.
But it was very well done.
Dr. Anjum, I want to ask one thing. Is there any scientific evidence for approaching such patients? Because earlier we would take the nephrologist on board and we would hydrate the patient, procedure, and later on we will again assess the
as mentioned by the presenter on the first or second slide, we have in hospital consultant nephrologist in PIC luckily, and this patient was kept for a couple of days before the procedure inside the hospital. He saw the patient, saline hydration was done, no other intervention or drug was used for his renal issue, only saline hydration and avoiding any nephrotoxic drug like ACE, that was done. And what was the second?
I was asking about the data, how frequently such procedures are performed globally.
So to us, we are planning to case report this one, because there is only one case report on left main LAD and circumflex nano crush with the zero contrast. There is no other case report at any other territory, and we will make it the first case report of LAD diagonal nano crush with zero contrast, hopefully.
You can use a little contrast for the patient's sake. And if there's any need, we can use the contrast like 5 ml per hour of the body cage, 5 ml per kg of the body weight divided by patient's creatinine. So this has been done in a Poseidon study as well, and we can continue the hydration period post the procedure. So we can use a little contrast in this type of a patients rather than little.
We can always use the contrast in the patient. Again, kidney disease is basically categorized in 2 main categories. One is AKI, acute kidney injury. In that case, I would like to avoid giving any ml of contrast, or if I can spare any single ml, I will like to spare. The patient who have a CKD, chronic stable creatinine around 2, 3 something, we routinely perform the procedure and we try to use ultra low contrast maneuvers, and that is one of the maneuver as said by you. You can give some contrast.
Dr. Najam, I have last question. Just in such a cases, what would be your preferred access site approach? The right radial you can spare for future arteriovenous fistula. Whether it is preferable to go for femoral approach.
Okay, yeah, that's very interesting. I personally prefer a femoral access for most of my CKD patients. But in the guidelines, I have seen that even with CKD, Dr. Aslan is there. So these are large young guys. As far as I remember, the latest guidelines, especially on the acute MI or primary PCI, if the creatinine is deranged, they still prefer a radial approach. So I don't know. Yeah. Yeah. But personally, I agree. Okay. Personally, I agree with your comment. If you ask my preference for CKD patients is again femoral, and the distal radial can be one of the options.
Because another teaching is that from femoral access, you can easily engage the guide catheter. You can manipulate your hard wires very easily.
Can you show the last view? There's another slide. Because I expected a question that how you engage the guide without giving the contrast and how you confirmed it. So but that question was not asked, but we had saved this slide for that. We saved luckily all the slides in the fluoro for our own teaching and for documentation purposes and presentation, because we wanted to case report this case. So this is how this guide was engaged over here. And the second thing is how you confirm that you are in the left main. So there is a technique which is present in the literature as well, and we confirmed it over in this case as well. After adequate back flushing, then you give pure saline. Then you give pure saline and a good volume and good speed. You give 8-9 ml of pure saline at a good speed, and you look at your monitor, and there would be transient ST elevation in that. So that's the way. But the thing is, again, you have to be gentle. While doing that, your left main, the guide should be coaxial, and your left main should be disease-free. These are the things you have to, keep in mind. So first check the pressure, your pressure curve, and then do adequate back flush, and then give a saline bolus intracoronary, and that will elevate your STs. So that was one question we were expecting, but
Thank you very much, Dr. Jalal, and nice discussion. We end up this session with thanks to high esteemed chairpersons. Thank you very much. Thank you, audience. Over to Dr. Fawad Farooq to proceed with the next session.